to our first Women's Leadership Initiative program of the 2021 academic year, leading at the intersection of public health and healthcare. We will be recording today's program for community members who were not able to join us. Today's program will be in the format of a conversation between Albany Law School President and Dean Alicia Ouellette and former CEO of MVP Healthcare, Denise Gonick. Their conversation will cover a range of topics related to leadership and the ongoing global pandemic while we get to listen in. During the conversation, please feel free to submit questions for our speakers through the Q&A. I will monitor the questions and will present them to our experts at the end of their conversation. We will try to answer as many as possible. And now it is my pleasure to introduce our guest speakers. Alicia Ouellette is the 18th President and Dean of Albany Law School. As a leader in legal education, Dean Ouellette has championed the value of law schools as drivers of change in communities, society, and the lives of students and graduates. As a scholar, Dean Ouellette focuses on health law, disability rights, bioethics, children's rights, and human reproduction. During the pandemic, Dean Ouellette served on New York State's Vaccine Distribution and Implementation Task Force. Denise Gonick is an experienced corporate board member and leader with 30 years of managed healthcare and corporate legal expertise. She is the former CEO of MVP Healthcare, a health plan based in upstate New York. Under her leadership, the company became the second largest company headquartered in New York's capital region at $3 billion in revenue annually. Denise also has deep experience managing compliance, government reform initiatives, government relations, and led MVP's first major acquisition as Chief Legal Officer. Prior to joining MVP, she practiced public sector, labor, and employment law. Thank you both very much for taking the time to join us today. I look forward to listening and learning from your conversation on leading at the intersection of public health and healthcare.
Thank you, Mary, and welcome everyone to this conversation. I feel like what we'd like to do is start by acknowledging that we're trying to have a conversation with you today about something that's still happening. And so, to the extent that we're talking about a pandemic, we understand that the pandemic isn't over yet. We understand that there'll be more things that happen, and that it's been a long road already for so many people who have been involved with this in whatever capacity they have been. And so with that as a caveat, and understanding that at some point when it's over, we could probably spend a lot of time digging into each of the topics that Dean Ouellette and I are going to try to address a little bit here today. Think of this as perhaps an overview, almost an executive summary of what those topics might be, and maybe the beginning of some thoughts that we can take home and perhaps do more thinking about, and then put to use for how things might change in the future. So that said, I'd like to give sort of an overview. When we talk about leading at the intersection of public health and healthcare, what do we mean by that? The healthcare sector in the American economy is huge. It, by many assessments, represents about 20% of our economy. Healthcare spending represented nearly 18% of the US economy in 2017. Total public and private health spending is the highest in the world in the United States, and was $10,586 per capita in 2018, just give you some sense of economic scope. There are more people employed in the healthcare sector than any other single segment of our economy. That said, the kinds of roles that they might have are incredibly diverse. And so when we think about the broad categories within the healthcare sector, we usually distill that down to the three major sectors. The first and perhaps the most obvious are healthcare providers. And when you think about that, think about the places within which you might receive care: hospitals, other medical centers, nursing, residential care facilities, physicians' offices, dentists' offices, outpatient care centers, medical and diagnostic labs. There are a lot of places that we go to receive care and that have something to do with analyzing the care that we actually need. And then there's the people. Sometimes we make the distinction between provider and practitioner to talk about the fact that when we say practitioner, we mean the people, the physicians, nurses, a whole wide variety of healthcare practitioners and technicians providing a wide variety of services. So that's the large universe of healthcare providers. Then there's life sciences organizations. Life sciences organizations are pharmaceutical development and devices, high-tech medical equipment. These are the kinds of things that we often get excited about, and we tend to think about when we think about the word innovation. What is the latest drug? What is the latest device or a new way of performing surgery? And then the third sector that you might think about are what we call payers. Payers can include government agencies. So for example, Medicare and Medicaid in the United States, private health insurance companies, whether they be not-for-profit or for-profit, all throughout the country, and then employers. Employers may make health insurance available to their employees, and then in some cases, they self-fund the cost of healthcare for their employees. And then individuals. And individuals can, in some cases, purchase their own insurance or their own healthcare coverage themselves and not have to go through either a government agency or an employer. And that's been a more recent development in our country. So I mentioned those three segments so that you can get a flavor of how differently somebody's work can be, and how differently, even within the healthcare sector, a company or an agency might have been impacted by the pandemic that we are continuing to live through. Overlaying all of that, I think, is public health. And what we talk about for public health is that it is the science of protecting and improving the health of people and their communities. So when we think about that, the primary thing to think about is that you're talking about an entire population, not just myself, not just my family, not just my company, but an entire community. And that community can be as broad as a country, or it can be as narrow as a neighborhood. When we think about how health might impact somebody and the kinds of conclusions and data that we might look at across a particular population. So I hope that's helpful in just framing the discussion for where we're kind of parachuting in to talk about the pandemic. With that as background, I'll just give you a little bit more background for myself. As Mary told you in the introduction, I was the former CEO at MVP Healthcare. I started at MVP as a staff lawyer. And so what that meant was, from the very beginning, I was involved in all aspects of the way a payer might interact with the healthcare system: contracts with physicians and hospitals, insurance policies that individuals would ultimately be governed by, or that needed to be marketed and sold, as well as how a corporation functions, how it grows, how it relates to all of those different components. I got to see a lot of change over the course of my career. I got to see a lot of different efforts in reform. I got to see things that worked well, things that didn't work well. I got to see how healthcare is deployed differently in different communities. MVP's footprint was across all of upstate New York, and we went into Vermont and for a time, New Hampshire. The way people experienced and accessed healthcare was different depending on where they lived. And that was true both within the state, so different communities. How things played out in Westchester might have been different than how they played out in Rochester. And that's an important lesson, I think, to be sensitive to when you're talking about healthcare. In more recent years, I got to help MVP implement the Affordable Care Act, which was a major reform effort in our country to help make healthcare more accessible to individuals that might be accessing the system outside of a traditional employer model. Health plan business is very much a mixture of traditional insurance concepts and principles, as well as health and wellness ideas. How do you take care of a whole person? How do you provide the most access? How can you give a person the most information that they need to make good decisions about their health and in fact improve their health and hopefully prevent them from becoming ill? It was great privilege to do that work. And I was very proud of the variety of people that we were able to serve at MVP. Since leaving there at the end of 2019, I am doing a variety of work, serve on different boards, but most relevant to this discussion is that I was a founding fellow with the Health Evolution Group. And that is a group of private sector leaders that is committed to continuing to improve and reform healthcare through the private sector and not just waiting for government reform. And our major work this year had to do with health equity, which we're going to get into a little bit more of a discussion on later on in the program. So at this point, I'll turn it over to Alicia to talk a little bit more about her background and get us started.
All right, thank you so much, Denise, and welcome to everybody. And we're going to do our best to make this conversational and go back and forth. But I'm going to talk a little bit about my experience with healthcare. Denise was really on the ground, right? She was doing the work of health law and making and providing access to healthcare. Most of my work in healthcare has been as an outsider, either as a lawyer in a case involving health issues, or as, and primarily as an academic, studying issues in healthcare and particularly issues that involve ethics and fairness in the system. How do we do our best for individuals, and how do we do our best for society? What should the rules be? And so a lot of my work has been to sort of push for ethical and equitable rules and distribution in healthcare. But more recently with the pandemic, as the law school dean of all things, I found myself having to be really engaged in public health decisions. And this is not unique to me as a law school dean. Every dean and everyone who's running any organization, whether it's a member of a school board or it's someone who has a restaurant, and small businesses, big businesses, we're making public health decisions. We have to make decisions about what's safe for the community. And in some cases, we have governments. We have, in New York for a time, we had a very, very prescriptive governor making some of these decisions. But there were still, even in that time, there were a lot of decisions that I and my team had to make that really put us in the position of making public health decisions. So it's been sort of a fascinating time where my academic background really has informed this new part of my job. And the other thing that I was able to participate in recently was this task force on vaccine implementation and distribution in New York, which I'm happy to talk about later when we talk a little bit about how vaccines were rolled out. But just as Denise sort of started us off by talking about the healthcare sector more broadly, just particularly for students in the audience, I wanted to spend a little time just thinking about health and how people get and stay healthy, and particularly about a concept that we call social determinants of health. So when we think about health, what makes us healthy? We often think about genetics. Do we have good genes? Are we predisposed to certain conditions? And access to care. Do we have a good doctor or nurse practitioner? Are we able to get in and see someone when we need it? Do we have health insurance? But there's also many social factors that really affect people's health and health outcomes. And when you think about this, it's not all that surprising, right? We talk about a healthy lifestyle. Well, what do you need to have a healthy lifestyle? So some of the things that experts have identified as being social determinants of health include things like safe housing, transportation. Do you have access to transportation? Do you use public transportation? Neighborhoods, racism, discrimination, violence, education, job opportunities, and income, access to nutritious foods, physical activity opportunities. Do you live somewhere where there's polluted air and water? Do you have language and literacy skills to get help when you need it, to understand conversations around health? So this kind of laundry list of social determinants of health contribute to wide health disparities in inequities in our system. So you can think of an example. So for example, people who live in an area where there's not grocery stores with healthy food. So we talk about those as food deserts, right? So if you live somewhere where there's not immediate access to healthy food, then you're less likely to have good nutrition. And in those households that are in those neighborhoods, that raises the risk of health conditions like heart disease or diabetes or obesity. And it even lowers health expectancy relative to people who do have healthy foods. And there's really good research showing that these social determinants of health really affect health outcomes. And the other thing that we've seen of late is that the COVID-19 pandemic has made these disparities in outcomes much, much worse. The disparities, I think we all saw while we were in lockdown, right? People who lived in multi-family homes where there's multiple generations of families, oftentimes in small apartments, or people who lived in congregate settings like group homes or prisons, people in inner cities who rely on public transportation to get around and so are forced to be with other people, were at far greater risk of contracting COVID than those who were lucky enough to be able to totally isolate in, say, a single family home. Frontline workers, nurses and orderlies, maintenance crews, security folks, grocery store workers, factory workers, that often people at the lower end of the socioeconomic scale, didn't have the luxury that many folks had to work from home. They had to go to work every day. They had to show up. They were not in quarantine and they were not remote working from the comfort of their homes in their pajamas, like many of us, right? So they contracted COVID at far higher rates than those who could work from home. And this played out so that certain communities had much poorer health outcomes. They already did to start with, so Black and brown communities, communities at the lower end of the socioeconomic scale, people with disabilities, communities of people with disabilities experienced much poorer health outcomes throughout the pandemic. And the social determinants for health, the things that affect the health outcomes, even got worse during the pandemic. So things like household income went down in Black and brown communities at a much greater rate than it did for white communities. And it was really across the board. So we see that we have a system that's a complicated system that Denise laid out that is trying to provide healthcare and to keep people healthy. And yet there's all these systematic and systemic issues that affect the ability of people to stay healthy. And we really saw that throughout the pandemic. So Denise, I'll ask you this. Are there any tools that those leaders in the healthcare sector can use to address health inequities?
Yes, I think that there are, and that there's been a lot more attention devoted to developing them. I can say this as background: the social determinants of health that Alicia was talking about is something that's been, well known as a problem in the payer community for a long time. And I would recommend, if people are interested in reading more about this, the Robert Woods Johnson Foundation did a program for many years where they were collecting data about the health of individual counties all across the United States. And they were measuring things that you might not have immediately associated with good health. We talk about the fact that your time with a physician or having some kind of a service at the healthcare system level might represent 20% of your overall health and well-being. The other pieces that make up 100% of the pie have to do with your education level. It has to do with your access to healthy food. It has to do with the amount of time that you spend moving. It has to do with your education level. So all of those pieces very much do affect people. And there was a movement afoot before the pandemic started to try to have insurers engage a little bit more in this space to try to make a difference on more of a community level. Perhaps one of the best examples I could give you of that is that happened down in the Bronx, actually. And it was through a Medicaid population where the incidence of asthma is very high, right? And so the insurer and hospital helped to pay for the installation of air conditioning in certain public housing apartments. And that made a huge difference. So when you think about it, you have the expense of interaction with the healthcare system, but doing this sort of more preventive step was more impactful. The great challenge that we've had has been, how do you scale that? How do you scale that, and who pays for it? These are the questions that really, I think, have confounded us through multiple cycles of healthcare reform. But we got very focused during the pandemic on, a basic principle in business, which is you can't manage what you don't measure, right? So the idea became, what is it that, we can start to measure that can give us guidance on additional actions that we can take. And so over the last year or so, we developed what we call a health equity pyramid. And what's interesting about the pyramid is that, when you're talking about a healthcare organization, you're talking about the people that work there. So all of the employees and workforce. And we thought about that as one side of the pyramid. And then you talk about the patients, the people who interact with the system and have a particular outcome when they do that. And we created 4 levels, and each level would be applicable to both the workforce and the patients. So think about it, 2 sides.
Denise,
and so where do we?
I'm sorry to interrupt you. Would you
That's
like?
okay.
I have the health equity pyramid. Would you like me to show that?
That would be perfect.
All right,
Yes, thank you.
let me share my screen here.
Thank you.
All right, are you seeing it?
Yes, that looks
Okay.
great. So this will help us all. Okay, so you see on the left side, the diversity of workforce and leadership, right? That it was recognized that one of the things that we need to work on is improving this. And I think that this is a theme that cuts across all sectors of our economy. I'm sure that you've read about this, that diversity, equity, and inclusion is just a major issue that all employers and organizations are confronting, sort of a recognition that we need to do more to help improve that. So we start at level 1 with just collecting the raw data, and we do that, we hope, with self-reporting. We're also looking to do that on the patient side. So the data set that we look to, we call REALS: race, ethnicity, language, and sex. And that's obviously data about employees as well as data about the patients. We've talked a lot in our group about how to optimize the accuracy of that and have organizations use as similar efforts to do that as possible. And then we stratify that so that we can figure out where meaningful disparities actually exist. So that's level 2, right? That you actually do the analysis of the data, both for your employees as well as for your patient base. Level 3 would be, and I should say on level 2, we talk about creating a dashboard. So for our data analytics friends who may be part of the discussion, again, we can't manage what we don't measure. So we need to create, a way to convey that information quickly. Also, you want to get that information in front of your C-suite, your senior management team, your board of directors, so that they can see, okay, do we actually have a problem? What are the problems, before they can then figure out what to do about it. And then level 3 is where the action happens. How do we actually make improvements? How can we, on the workforce side, facilitate recruitment? How can we reach those populations that we don't seem to be reaching? Is there something that we're doing that is preventing us from getting there? Likewise, on the patient side, how can we embed those interventions right into clinical workflows? I'll give you another classic example. A hospital system in California talked about having a very poor attendance rate with follow-up appointments within their Asian patient base. And they realized that although they were sending texts out and things like that, they were sending them in English. And the majority of that population, that needed to be sent in Chinese and Cantonese. So simple thing that seems obvious, but if you don't ask, you won't know. And that's really what the spirit is of this. And then we would love to see us get to the point where we can make these things public. I don't think there's too many organizations that are there. And to be fair, this paper with the pyramid just came out like a few weeks ago. So it's very, very new. And it's sort of encouraging other organizations to adopt it. Many organizations in healthcare have to collect data and use it for so many different reasons. They use it for their accreditation. They might use it for grants. They might use it to be evaluated by other organizations to make them a center of excellence or something like that. Also on the regulatory side, the health department collects so much data. So there's always a concern when something new comes out, is this another thing that we need to do? Is there a way to build it into something that we're already doing? And so, ideally what you'd love to say is that this is quality. This should be something that you're measuring and then you can hold people accountable for. And a lot of how health providers get paid has to do with incentives that they will only get if they score well on certain levels. And so it's all about deciding that this is a priority. So ultimately, we'd love to get to that place where we have something that is public facing. I'll talk a little bit just to kind of go back to our first discussion about the healthcare sector, how something like this might be used across the three main sectors. So for payers, the one I'm most familiar with are utilization rates of primary care as well as specialists. That's something that you're always looking at. And we have a saying that 20% of the population tends to create 80% of the cost, right? Why is that? Are there interventions that we can take sooner? So that's like part of how you try to discover the linkages in people. Another thing that we look at is net promoter score, which is traditionally very low in the health insurance field, because that has to do with how often your members would recommend you, right? And health insurance is often perceived as a barrier that people have to get through. But it gets at this more nebulous idea of someone's experience and whether the experience is good or bad, and to what extent you can influence that. And if you think about that, that has become a measurement in every aspect of our lives. You get a survey after every transaction that you have, after every service that you have, asking you if you were happy and what can be done better. And I was a believer that health insurers should be no different, that you're on a path to improvement. With providers, of course, there's all kinds of data that you might collect. Another area where we've often seen disparate results was on maternal mortality rates, particularly for women of color, that they were a lot worse than they were for other women. Why is that? And seeing that number and being able to develop an intervention is important. Cardiology, things like blood pressure, diabetes, things like having your A1C in the target range. Cancer, have you had your appropriate screenings? These are all things that providers would traditionally be looking at. For a life science organization, medication adherence is the big one. So, they develop these drugs, and then there's often times people will start taking them, but they don't continue to take them. And then they might have a bad outcome, or clinical trial participation rates. So that was the spirit of the health equity pyramid. I would say the conversations around building this were unlike anything that I've ever participated in. Some of them were very uncomfortable. People talking openly about what their experiences were moving up in an organization or not moving up in an organization, and really trying to confront that. So I think, as difficult as this work is, ultimately I come out both happy and optimistic that we're actually trying to develop a tool where you can do something about it and begin to measure it. So with that, as kind of our discussion around disparities and social determinants, I thought perhaps we'd turn now to the vaccine and the vaccine rollout, which has gotten so much attention. And I know, Alicia, that you were very much involved in that. And I'll turn it over to you to share some of your thoughts about it.
Sure, thanks. And it's so interesting to hear you talk about getting to the health equity pyramid and some of those tensions among health leaders that are trying to do the right thing, right? And we saw some of that with the initial vaccine rollout in New York, and that was where my experience was. So that's what I'll talk about. It was really sort of, there was an internet meme, how it started, how it's going. And it was really, there was a very different start to how it went when the vaccines were first approved. So the vaccine rollout started with bringing together in New York public health experts and ethicists and clergy people and people from the community And there was a really good plan for equitable distribution of the vaccine that was based firmly in public health principles and prioritized groups that were either at a special risk because of their own physical state, high risk populations, or because of their jobs. So prioritizing first essential healthcare workers. There was a matrix that involved sort of looking at who's at most risk because of the geography that they live in. Let's get where there's the most COVID. Let's get the vaccines out first. Lower risk populations next, and essential workers and general populations. And there was a phased rollout plan. It was, and it was really, I felt really proud of the plan that came out of New York. It was very well done, but it was a plan. And then vaccines became available, and once vaccines became available, there was some of the decision making changed, some of the decision makers changed, so that even initially, the initial phase 1 of the plan said healthcare workers who work in patient care settings, so front-facing healthcare workers and long-term care workers who regularly interact with residents should be the first to get the vaccine, together with the most at-risk long-term care facility patients. Well, what happens, or how it started, how it's going? Hospital systems started to vaccinate everyone that worked in the hospital, whether or not they were front-facing, and there were all kinds of reports about board members of hospitals getting vaccines first and jumping the line. So you saw there was a decision made that was not part of the initial distribution plan, that there would be hospital hubs that would control the vaccine distribution. So it created this potential for this jumping the line that was somewhat anticipated, but it was really it was not the best moment for New York. And then things went off script, and there were the mass vaccination centers open. Now again, this was something that was done with the best intent. How can we do this the fastest? Well, a bunch of people in a room say, what we can do is we can take over SUNY Albany, and we can have hundreds, we can give hundreds or maybe even thousands of shots in a single day. We're going to create a system that's completely fair. You get on your computer, and whoever signs up gets the spot as long as you're in one of the eligible categories. What happened with that is, if you went to one of those centers, there was a real disparity in the races of the people that were getting vaccinated first. White folks were getting it first, and it goes back to some of what we've been talking about equity and systemic barriers. The system that was rolled out in the beginning was one that relied on technology, and it relied on individuals having transportation to these mass vaccination centers. Now, to New York's credit, the leaders did recognize this issue, and that you had the county leaders and others say, we got to change the way we do this, and that in order to make sure that Black and brown populations get vaccinated, that people who don't have transportation get vaccinated, we've got to bring the vaccines to the community. And we also have to think differently about who's going to be promoting vaccines. We can't, and this was something New York talked about very early, but we can't just rely on doctors. We've got to rely on who's most trusted in the community, who's going to be the spokesperson for getting vaccines out to the community. So there has been a huge, at the beginning, everyone was trying to get the vaccines, and the issue was sort of the Hunger Games nature of it, that those with the most ability were able to get the vaccines first, and then you saw vaccine vaccines being brought into communities, going to community centers, going to churches and places where individuals who might not be able to get to the mass vaccine centers were, and you saw a good uptake. And then there was an entirely different shift. All of a sudden you went from not enough supply to not enough demand. And that was a bit of a different problem. But there were some things that went well with the vaccines, and maybe Denise, you could talk about some of what, I mean, that this has been a really complicated story of vaccines, not only in the rollout, but in the development. Maybe, could you talk about that a little bit?
Sure. Yeah. I mean, given where we are today, it's very easy to dwell in the land of how it's been rolled out and why aren't we higher in our total percentage of the people who've taken it. But what we take for granted is that it's amazing that these vaccines were developed within a year, and that really in many ways reflects the best of the innovation that our system offers. When I was a CEO, I was a big believer in public-private partnership, because I think in healthcare you have to do that. You want to use the best of the private sector, provide incentives, for their discovery. And although it might have seemed to us to have been so fast, the messenger RNA model of delivery was something that scientists, I believe it was a woman scientist, had been working on for many, many, many years. And, and now this was the moment where it got to be deployed. And that's very exciting. And I hope that when we get to the true end of this, that we'll be able to look back and really tell those stories and celebrate them for the many people who have worked so hard, to try to find solutions. So I do think that was a success story. The other thing, I mean, I know we want to talk a little bit about, some of the conflict and challenge that we have right now playing out in real time about, private individual freedoms versus public health, for people who are resistant to the vaccines. And one thing I would say from the perspective of having been a healthcare leader is we did see some healthcare leaders begin to speak out in encouraging vaccine uptake, both publicly as well as issue mandates of some kind for their organizations, certainly before there was any kind of a federal mandate. And, now you're sort of getting into a whole, leadership question, and what should CEOs be talking about? And, why might a CEO be willing to do that? And I think that there's a lot of pieces to that. Running a healthcare organization is not the same thing as running a manufacturing organization. And you have a mission. You have a mission that when you're talking about people's health, I think you have to have a certain amount of credibility in being willing to talk about that. But that being said, that alone isn't enough. And so in hearing from some of the CEOs that did take these steps earlier in the summer, what they shared was that you had to totally be willing to engage in what they called radical communication. And by that, what they meant was trying to reach not everyone. So people who might disagree with you, and understand that the people who have been resistant to vaccines are not monolithic. There's a wide variety of reasons where they might be resistant to it. We know some of that has to do with the disinformation that is now able to accelerate quickly because of our social media and internet lives. That is extremely difficult to combat. It's so funny that we have this happening at such a rapid rate, and yet the way we combat it is through one-on-one conversation, right? Being willing to listen to someone. Another piece also that Alicia touched on was that for many segments of our population, there isn't necessarily trust in any authority, including the medical establishment. And there are historical reasons why that might be. And so now we're living at an age where a CEO has to be willing to listen to that and engage with somebody who might have had negative experiences and acknowledge that in helping to build the trust that's going to be necessary to help someone make that decision for themselves. So I think that really can't be understated, the importance of communication way more frequently than you think you have to, and through multiple channels in trying to reach different people. It is a huge effort, without a doubt. And that fundamentally, we are talking about trying to, in some cases, rebuild trust, and in some cases, build it for the first time. And it's interesting, just from a pure leadership perspective, that the private sector, in many instances, finds itself in this moment, because at the risk of just touching on our divided politics, the traditional thinking is that CEOs shouldn't wade into that. But I think two things. A, healthcare is healthcare. Healthcare is different, and there are reasons that you have to wade in and begin to understand why somebody might be disagreeing. And two, there are so many things that separate us, but one of the things that unite people is where they work. And we may not think about it that way. There's a lot of isolation in our world today, and communities may not be communities in ways that we used to think about it, in the ways that people maybe used to all see each other at the same religious institution, or maybe even educational institutions. But most people work. Most people have a job of some kind, and they interact with people outside of their bubble because they work with them. And so I think for CEOs today, I'm not at all suggesting that that's easy, but that is the road to try to walk, and to make yourself vulnerable and be willing to do it in the space that intersects with your mission, because you have a mission when you're running a healthcare organization.
Yeah, it's so interesting, right, that CEOs of big companies, but also little, small businesses, and certainly in higher ed, these private individuals making these hard calls on vaccine mandates and mask mandates. I mean, they're making public health decisions for their company, and I think you're right that it does place leaders in a position of having to kind of take something that they may not. It's about health, and it shouldn't be politicized, but it is. And I think it's particularly interesting what you're talking about here, Denise, given the real divide that we're seeing in our country around sort of protecting the social good in the community versus individual freedoms, right? This idea that it's always been part of our country, I think, to some extent or another, that we're the land of the free and the home of the brave, right? And so we can make decisions for ourselves, and we have individual rights, and that's very much part of our culture. But it's playing out in a really different way in a pandemic, this pandemic, than it has in the past. We have a really long history in this country of deferring to public health officials, of doing things for the collective good, of allowing government in particular to make decisions to protect all of us, to say you have to wear seatbelts, even yes, you have to get vaccines. So there's a decision that everyone in health law has talked about for years, and now not everyone knows, but a lot of people if you're talking about vaccines, you've heard of the Jacobson versus Massachusetts case, which is one that went to the US Supreme Court, that challenged a vaccine mandate in Massachusetts for smallpox. And it was upheld, and the court was incredibly deferential to the public health experts. The plaintiff in the case was someone who didn't want to get vaccinated. He claimed that there would be negative health effects for him if he got vaccinated. He had his people, his so-called experts who were willing to testify. The court said, we don't want to hear from your experts. We have a public health, the officials who know this, courts shouldn't be listening to which experts are smarter. It's the government that has this obligation to take care of the public health, and can, if it decides that that requiring vaccines of all the individuals is what's needed, then that's what the government should do. And Jacobson has taken some blows in the Supreme Court recently, as there have been some challenges to some of the regulations that have been put in place, particularly in New York and in California, and is really being challenged with respect to religious liberty, the rights of free exercise of religion, and the rights of individuals to make decisions there. So you've got this backdrop of public health law, and then you've got these leaders in industry having to try to put a stake in the ground and to make a decision for their companies that's going to be the best thing for maybe for business reasons, maybe for the health and safety of their workforce. And I think it's a really tough time to be a leader, to be dealing with all of these questions.
I totally agree. You know, the other thing that's interesting about that is it didn't get much play, but there were actually bipartisan policy leaders who, published op-eds in various papers in early August before there was any kind of mandate, really just, really encouraging people to take the vaccine and talking about how safe and effective that it actually is. You can find Alex Azar, who was previously the head of HHS on the prior administration. I've had the good fortune as part of Health Evolution to see, prior leaders of CMS, and from both sides of the aisle, so to speak. There's a remarkable amount of continuity in a lot of their work, and they support each other. So there isn't any of that. There isn't conflict where there isn't conflict, and that maybe is something that people could think about as they ponder this.
Yeah. Where do you think this push for individual liberty around healthcare decisions that affect other people is coming from? I don't mean to put you on the spot with a political.
No, that's. Yeah, I do think it's clearly in the spirit of the American experience to always be focused on individual rights. But what's interesting to me too is the perhaps lack of self-awareness around how much risk that we all accept on a daily basis without thinking about it. So I do think, not to be too cynical, that we are also living at a time where we tend to be very like, what's best for me? And that there isn't as much in the national dialogue about what's good for everyone. And I do think that that's a change, because that's something that, frankly, both political parties in the past used to try to own in some way. And I just don't see that as much. And maybe that's an inevitable part of the evolution of our communication, and that we're going to come back around to it. I hope that will be the case, that we come back around to it in a different way as we try to balance these things out for a modern time.
Yeah, well, that would certainly be a good thing to come out of pandemic if we can get there. I
Yeah.
think we're still really deep in the hard part of pandemic as we try to call
Yeah.
out and look to leaders. Is there anything else you think that would be a sort of a lasting benefit or lesson learned from the pandemic? Is there anything good about this whole thing?
Yeah, I think there are a couple of good things. And one thing I'll say, just to stay on topic with healthcare, is the uptake in telemedicine. MVP was an early adopter of telemedicine back in 2016, I think, was when I really believed in it. And I thought that was just going to be an inevitable part of the future. And I saw even back then that it would be particularly helpful in the behavioral health space. It's just so easy. And, for people to be able to engage with a therapist through this kind of a format. But, like many innovations, it just was not really well accepted. And there was a very small, I think, subsection of the population. And clearly now with the pandemic, I think understanding that telemedicine has a role, I think we have really probably made more advances in the last 18 months than we had in the last 18 years. I mean, there are people that have been pushing telemedicine for a long time. I am not suggesting that it solves everything. It certainly doesn't, but it does enable a lot of things to continue. People who are already in treatment, things that can be triaged, things like that. Like so many things in healthcare, a lot of that will also come down to reimbursement rates and whether or not, those will be sustainable for people going forward. I think physicians, hospitals, they're constantly trying to reinvent their businesses to figure out ways to make it sustainable. But I think telemedicine, everyone acknowledges, is here to stay, and that's going to be part of the solution. I think another would be, more on the workforce side, that these technologies in the way that we work, I think, are here to stay. And there are, many discussions that I participate in around what is the workforce of the future? What is the workplace of the future? Is the office going to come back in exactly the same way? Now, understanding that people have a wide variety of work that they do, certainly for office work, it's hard to imagine that remote work won't be part of that equation. And so that can be very good, I think. I think that can give people opportunities that maybe having to move for a job would have never allowed. On the other hand, I think that the way that we network and interact with people probably has to catch up. There's always, in the workplace, there's, the building of relationships. There's what happens in between classes or in between meetings, what happens at the water cooler where you truly get to know someone. So we talk a lot about how to bring that back to it. And again, it's sort of like the earlier discussion, how to balance the needs of the individual with the needs of the many, to try to have as level of a playing field as you can for everyone. But I do think that it's now shown that these things can work. And so you can't go back to before and say that it won't.
Right. And I actually think some of these things it affects health, right? If people are spending less time commuting, they have more time to exercise if they want to, or right. So some of those changes, and I think the community stuff really matters. I mean, we've definitely seen this at Albany Law School, that while there's a national divide within smaller communities, you do see individuals stepping up to help other people, and they do it in big and small ways, and that's pretty inspiring. And I do like to think that some of what we've seen during the pandemic will continue. So it looks like we might have some questions. Mary.
And I hate to interrupt this conversation because it has been so incredibly informative and really interesting. So thank you both very much. We do have a question that was submitted to us, so I will read it for both of you to consider and respond. Poor individuals and individuals of color are impacted disproportionately by chronic illness and COVID. Advances in life sciences have allowed better tools for individuals with chronic health problems to live independently in their communities. These tools include not only better, more effective treatments, but also better technologies which allow for telehealth monitoring of these individuals. Many of these individuals otherwise live isolated lives and need some assistance with daily activities as well as social emotional support to improve their mental health functioning. A national and regional shortage of home healthcare workers contributes to these individuals not receiving the support they need, leading to costly health deterioration or the need for care in more restrictive settings. How are health leaders addressing this problem in terms of increasing the availability of these important service providers, expanding funding to cover what might otherwise be considered custodial non-medical care?
Okay, well, there's a lot there. And I think it's a great question. And what it demonstrates is that we have placed value on certain things as a society higher than others. And it does remain the case that probably, I think we've seen this play out in other aspects of the pandemic economy. Some of the lower paying fields end up being the most heavily impacted in the sense that, you know, they just don't want to do it. And if they're in a position to be able to either have a benefit paid to them or to choose something else, that's what they do. So I think, you know, we talked about healthcare practitioner shortages of a wide variety in different parts of upstate New York. I think it's been a problem, especially in rural communities. So I think one part of it is valuing those roles as much as possible and understanding that means trade-offs someplace else. So that is always the difficult problem there. And then I think doing what can be done to try to encourage people to go into these fields is another piece.
Yeah, and I think that there's some, I mean, it's a huge problem, right? Social isolation, medical isolation of people with chronic illnesses. What Denise was talking about earlier about telehealth, actually having telehealth visits be reimbursed is going to make a difference because it will become more available and you know, the providers will be more incentivized to do it. There are health leaders that are working on new kind of models of care delivery or in health that are really focused on outcomes and quality, and so are addressing social determinants of health. And I know Denise has been involved with some of them, and there's some new, sort of brand new insurance models coming up where providers will be paid for health outcomes. And so I think that there is thinking around the broader issue that encompasses some of what the questioner is asking about in terms of, you know, should, if we're really thinking about individuals' health, and the goal is health and not just to provide care, but to get people healthy. It's not just about the doctor's appointment. It's about getting those home health aides there. It's about, we know that isolation is actually one of the factors that leads to worse health outcomes. So what can we do to address that? So there are people thinking about it. I think right now we're still in a health crisis with pandemic, and it's, I don't know how much energy is going into that, but I think it's a really good and important question.
And I should add, you just made me think of it, Alicia, that, you know, this idea of private private public collaboration is something that has always been pushed by CMMI, which is the Center for Medicare and Medicaid Innovation. And those models of care that you referenced, you know, value-based care, we would talk about it, was the goal. But, you know, there may have been a drop-off. There has definitely been a drop-off in terms of some of those programs. There is a desire, I know, to get back to that. And I definitely can see that as more of a kind of post-crisis pandemic solution. Because the other thing that I think the questioner is getting at is being able to stay home, you know, aging at home. We know from, there's a lot of data that shows that the longer a person can stay on their own, the healthier they tend to be, and the better the outcomes they tend to have. And so making that happen, though, is going to require a number of different interventions, probably some related to telemedicine, some relating to, you know, the diagnostic and monitoring that you're talking about, that the questioner referenced. And it kind of involves really rethinking the way the system works.
Right,
So,
right.
yeah.
Creating new systems and bringing in community partners that do some of this stuff,
Yeah.
right? And so there are organizations that are trying to do that, to bring together all, you know, the social services agencies and food banks and, you know, all the different components to address some of these social determinants and create healthier lives so that people can stay at home, so that people who are home because of chronic illness are not isolated, and there are models out there. So hang on to hope, right, I guess.
Well, that's fantastic. And thank you so much, both of you, for addressing that question. So I don't see additional questions at this time. So I'm going to end the program with one of my own, if that's okay with both of you.
Sure.
I heard, first of all, I learned so much, and it sounds to me like one of the things that maybe we've learned through this COVID experience is the potential for both private leaders to be very impactful when it comes to public health. And another theme that I heard a lot about today is the idea of a public-private partnership to address many or some of the factors around social determinants of health. So I'll ask each of you, where do you see opportunities in the future for these types of innovative partnerships to perhaps better help to answer some of the questions around creating a more equitable healthcare for everyone in the future?
Yes, I'll jump in first. I think that there are these people working on this, and really there's some pilot programs out there. I think part of the key is getting the right people at the table when decisions are made about policy generally, right? So I talked about the vaccine rollout, and I think part of what went wrong in the beginning was that the conversation was really healthy and robust and about equity and fairness and public health, when it was a group of sort of the right people at the table. When it got put into the hands of the politicians, it became different. It switched, and I don't think it was bad intent. I think everyone really intended to create a program that was going to be great and get vaccines in arms. But you gotta have the people on the ground. You gotta have the people who understand what it means when you create a system that relies on the internet speed, right, or on transportation. That we need to be mindful and very purposeful in bringing equity considerations into play in policy. So I think that could help.
Yeah, I think that that's, it really speaks to already a lesson learned right here. So we're in the middle of the crisis, but Alicia's able to reflect on just what's happened in the last few months and to see how that played out in real time. And by the way, I would say, to anybody thinking about this from a pure, management leadership perspective, if you took a course on crisis leadership or crisis management, I think you'd be hard pressed to find anything that's quite like this. Most of the time, a crisis is like an event that happens and then it's over. And you might not know everything, but a lot. The terrible, the plane crashed, or the product failed, or something like that happened. This is like playing out in slow motion, right? And I think the other piece that we're dealing with is that at the same time as you have this loss of trust in expertise, you also have information available to almost everybody in real time. And the reality is that when you have something like this that's happening, you can't know everything at every moment that you nevertheless have to make a decision on. And guess what? That's what it takes to be a leader. You never have perfect information. You have to be able to act based on what you know and make the best decisions possible. So, I think that's something that everyone, any lawyer should be able to relate to that. You can only deal with what you know. So I think the opportunities are going to very much be around, okay, how can we take what's happened here and then do a program, whether it's through our Medicaid program, or some other federal grant designation to experiment in these communities, and to bring, I think, the level of honesty and vulnerability that is necessary to acknowledge what went wrong. That would be the place to start.
Thank you for that, both of you. So we did have one more question come in, and so I will go ahead and ask that before we end our program today. The question is that it seems patient care and access to care will be negatively impacted by the healthcare worker vaccine mandate. What lessons should CEOs consider implementing? What lessons should CEOs be considering when implementing their own mandates? And what should they take away from this regarding unintended consequences?
Well, I think, one of the answers there is that you have to anticipate resistance, obviously. So, that was a lesson learned for some of the people that tried to do those mandates early on. And then you got to just work through them. You have to work through them. You have to understand where the resistance is coming from, and that many people are capable of getting over their resistance. And so I think that that's an important lesson, that that's not a monolithic block. I don't know, Alicia, if you have other thoughts on that.
I think that's right. I think that the decision, a decision to mandate anything in the workplace, it's really tough, because you're going to have people who don't like it. Employers have all kinds of requirements and restrictions, and you have to do this and you can't do that. And the vaccine question has taken on a particular intensity, and there is pushback, and I think Denise is absolutely right. As a leader making that decision, it's many layered. Is this the only way that we can really operate safely? Are there alternatives? Do we want to have carve-outs? If we can't have carve-outs, what are we going to do to help those who, or with or without carve-outs? How do we help people who are resisting? No leader is making a decision to have a vaccine mandate because they think vaccines are bad. They think vaccines are the way to move forward and go through this. So, so who can be helpful in answering the questions and taking the time to help people get through whatever the resistance there is, and knowing that every decision you make as a leader has some consequences. And sometimes, unfortunately, it's that a particular person may not be the right fit for the organization because of a requirement. But you hope that you can deal with it. So I think that these are really, really, hard and important decisions that are being made, and we're seeing how different shapes of the vaccine, the decision to have vaccine mandates plays out. In some places it's a mandate, but there's a test out requirement. In some places it's a mandate, but there's a religious exemption. And then in some cases it's a vaccine mandate with no exemption whatsoever. And so the more restrictive it is, the more resistance that there's going to be, and from a legal point of view, we'll see how the legal cases challenging these things play out. But from a leadership point of view, each of those decisions is going to have implications. And I think that we as leaders have to kind of decide, all right, if I'm going to make this decision, what's the sort of cost benefit, and how do I help my people understand? And before Denise talked about radical communication, if you're going to have a very restrictive rule, very strict mandate, you got to really explain why, and what is it that you need to be able to work with this. So I think, it's big challenges.
Thank you. And so I want to say thank you so much for your leadership, both of you, both Dean Ouellette and Denise. Thank you so much for sharing your insights with us here today and for allowing us to learn from your experience. I am so grateful.
Can I need to make a plug, or I'm going to be in trouble. For any of our alumni or students are hearing this conversation and are interested, we do offer an LLM in health law and health law compliance online our graduate programs. And if you're interested in these issues, take a look and see if it might be for you. We'll talk at the end.
It's a great field, and thank you for having me. It was a great conversation.
Yeah, thank you, Denise, and thank you, Mary, and everyone with the Women's Leadership Initiative.
Thank you very much. Have a wonderful afternoon, everyone.